Okay, so my lecture today, I am Ronnie, PGY4, about to leave New York. I'm going to try to hold it together for 30 minutes or so. But I'm not gone yet, no. I mean, mentally maybe, but physically still here. This talk is actually something very new for me that I tried to put together from scratch, and there's not a lot of data to make this significantly evidence-based, so a lot of this is going to be feeling and emotions-based, and I'm going to ask for some participation from the audience at times, and so I remind everybody that if you're on mute, you just have to hold your spacebar button down, and you can talk, and it'll actually unmute you while you're holding the spacebar, so it's kind of like an unmute button. That way you don't have to go clicking and searching for the button to unmute yourself. I also have the chat open, so if you have questions or you don't want to say it out loud, you can, or interrupt or whatever, you can always just type it into the chat and I can see it. Otherwise, I'm okay to be interrupted at any time. I don't mind. So, yeah, so I started to try to think of things that I could talk about for my senior lecture, and I think you all know that I have a pretty bold and aggressive approach to things related to sex and sexuality. And I started to think about how we approach some everyday relationship or interactions with patients in the emergency room with regard to not just the sex, like the physical act of sex, but sex as in gender, sexuality, and some situations that we see in the ER where, which are the result of sex and sexuality. So my presentation is on how to be a sex-positive doctor. It's basically a how-to guide on some difficult conversations with patients. So I know what you're thinking.
Come on, let's talk about sex, baby. Let's talk about you.
But actually, my lecture is more designed to be an introduction to something called the sex-positive movement. I'm going to try to use 5 at-risk populations that we deal with frequently in the emergency room to give you some how-tos and some understanding behind the delicacy with which we have to handle these situations. So basically, issues regarding biological sex, sexuality, gender, sex. For LGBT patients, HIV-positive patients, patients having a miscarriage, patients with an unwanted pregnancy, and patients who've been sexually assaulted. And ideally, you can help improve your patient's experience and improve your comfort in these types of situations, which can often be very uncomfortable for us. And yes, Taharka and I did plan our lectures together so that we wouldn't cross-cover a lot of the same things, and you would get some good widespread education on it. So I start with this statement that as emergency physicians, we serve at-risk populations. Basically, we see LGBT and T patients. We see frequent flyers. We see patients with psychiatric disorders, patients who have no insurance or limited amounts of insurance. We see women. We see the elderly. We see patients of color, minority patients. We see children. We see the incarcerated or soon to be incarcerated or potentially to be incarcerated. And we see the poor. And so this essentially, you've heard the old adage that we are guardians of the shallow end of the pool, lifeguards of the shallow end of the gene pool, right? But in this situation, I challenge us to say that we need to be guardians of the at-risk patients that we do see. So because they are so high risk, I hope to help you understand why and what you can do to make it better. So the question is, why is it so important that we make these interactions with our patients effective interactions and that they are considered positive interactions? So I tap on a psychological theory called social cognitive theory, which says that adult learning takes place in 3 different domains to determine our behaviors, essentially. There's this personal domain, a behavioral domain, and environmental domain. And these all interact to help us decide what we do and why we do it and how we do it. So starting with our own behavioral factors, these are things like, do we feel like we have the ability to do it? Do we have the skills? Have we practiced doing it? That will be before we take an action. That's how we assess our success or failure beforehand. There are also these environmental factors which become very important in the emergency room, but things like social norms, access, and influence. And these change with time, these change with different populations. And it's important to remember that patients often belong to different sets of environmental factors. And then there's these cognitive factors, which are also kind of personal as well. So like whether a person has certain knowledge or has certain belief in themselves and their attitude towards success or failure. But what this really comes together and it is saying is, if I am going to go to the emergency room for care of a medical condition, I don't just go, I need to get care, and I go to get care at the emergency room. I take into consideration several other things. If I'm a transgender patient, what have my transgender friends experienced when they go to the emergency room and told me about when they went? What has the media showed me about attitudes in the public about transgender patients who are seeking medical care? What do I hear my parents or my school or the radio say about transgender patients? Or what do I see on the internet? How do people treat me in general in public? And I apply all of these things before I make the decision to seek out care. So understanding that this is kind of a full contextual approach to how people seek care, it becomes our opportunity to take every point of care with that patient and either make it a positive or a negative experience for that patient. So this will determine how they're going to interact with the medical community going forward, potentially. It affects whether the patient's going to take their medications or not that you've prescribed to them. It affects whether they trust you as a medical provider enough to take your medical advice, or trust the medical community enough to even seek out care in the future or in this particular interaction. So for these at-risk populations that I want to talk to today, I'm going to introduce you to something called the sex-positive movement, and then hopefully we can frame some of our interactions with patients understanding it. In 2016, the World Health Organization said that sexual health is a state of physical, emotional, mental, and social well-being in relation to sexuality. It's not merely the absence of disease, dysfunction, or infirmity. Sexual health requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences, free of coercion, discrimination, and violence. So that kind of leads us into this sex-positive movement, which basically gives us acceptance of all forms of gender and sexuality. It compels us to look at sex, gender, and sexuality having overlapping cultural perspectives. It asks us to help define someone's sexual relationships, sexual preferences, and understand that misunderstanding of those or uncertainty about those can create this cognitive dissonance where people feel ashamed or feel embarrassed by their sex and sexuality. Another component of the sex-positive movement is that we need comprehensive and accurate sex education, not just in elementary schools, middle schools, and high schools, but in our continuing education as physicians, nurses, PCAs, as we're talking about. So a huge component of the sex-positive movement is actually bringing back thorough and comprehensive sexual education so that people are being exposed to this from much younger ages and growing up with it as part of the didactic curriculum. Another portion of the sex-positive movement says that all types of relational or relationship and sexual connectedness are valuable as long as there's consent, honest communication, and safety among all parties involved. To quote one of my best friends, he always says, consent is sexy. And that's how he ends all of his emails. So the pictures up here are showing you that there are a wide variety of sex and sexual practices, but what is most important about them is that the person who's engaging in those sexual practices receives something positive from that, a positive feeling, a positive relationship. The hope of the sex-positive movement is that by combining all of these elements together, you create not just an emotional wellness, but a physical wellness, that you can have safe, consensual, and pleasurable sexual experiences. Have safe and functional and satisfactory interpersonal relationships, not just sexual relationships, but the way that you relate to people around you in everyday life. And not just sexually, but emotionally as well, because we do have emotional relationships with people that we're not physically intimate with. Okay. So the ways that this goes wrong and the things that the sex-positive movement is against is, one, pathologizing sexual acts. So like Taharka spoke about referring to being LGBT as a pathology, or transgender as a pathology in the DSM, which was recently undone. Part of it also is that we shouldn't be blaming individuals for what they like and conversely what they don't like, because there is such thing as people who are asexual or uncomfortable with sexual physical contact, and they shouldn't be shamed or coerced into doing things that they aren't comfortable doing. So most importantly, the thing is there should be no shame associated with it, and we should not be pushing shame onto others based on our own personal beliefs, especially if what they're doing is positive for them and makes them feel happy and good and improves their relationships with others. So taking that framework of sex positive ideals, I want to now look at some of our more at-risk populations and see how we can apply that to our patient interactions. So I'll start with LGBT patients. So here are some of the problems that we have with LGBT patients. Education. Taharka and we actually used the same study. There was about 130 medical schools who said they have an average of 5 hours spent on LGBT in education, and many of them said 0 hours. That's how they got the average of 5. But if we look at residencies, they surveyed approximately 120 emergency medicine residencies and found that they have about 45 minutes to 1 hour of LGBT curriculum per year. Religion. Religion becomes problematic because in many of the religions that are common in the United States, being gay, bisexual, transgender are all considered not in line with the ideals of those religions. Here in Kings County in Brooklyn, we have a very strong cultural component that we run into problems with. Haitian, Jamaican communities, often LGBT and T are not considered are not considered fondly. And you can see it a lot of times with how our nursing and PCA staff and even some of our physician staff interact with patients. Legality. In many states, or countries I should say, being LGBT is considered a crime and you can be arrested or even killed for either being or participating in acts. And then on the hospital side, we have problems with policies. Some places don't have policies in place that allow us to protect our patients, and some hospitals actually have policies in place that prevent protection of LGBT people. For example, not allowing partners unless they are, married by state law or things like that into the room, or not considering somebody's partner next of kin when medical decisions are being made. Actually, Tarek and I both talk about Logan's study. Another portion of Logan's study that was really interesting was all of the people who were surveyed said that one thing that they wanted people to know was that whenever a provider was not comfortable with a topic relating to that person's care, instead of acknowledging that they weren't comfortable with it and saying, I'll find out, I'll look it up, they kind of doubled down and got more aggressive and more like, respect my authority, I know more than you do about this. And really, it affected their patient interaction. And it created a negative experience for almost all of the patients in the study who said that they experienced a provider who wasn't comfortable or familiar with their care. So we have to be careful doubling down on our authority as the person with the most knowledge, especially if we don't have the knowledge or we aren't as familiar. So what can we do? One of the things I always say is recognize your personal biases. If I came into you to the ER and I said to you, last night, my partner blindfolded me and tied me to the bed and had 4 other people come and have sex with me, and today I have anal pain. And I held up a mirror to your face and I said, what do your faces look like right now? A lot of people have kind of wide eyes or like, wow, looks on their faces. And it's that simple moment where you have a response to the patient's complaint or the history that the patient is giving you that sets the tone for your interaction with them. And so we have to be really careful about practicing our doctor face, practicing our understanding faces and knowing how we're going to respond to what the patients say to us so that we don't make them feel bad. We should standardize our sexual histories. So we are taught in med school, one of the things that most people in the surveys from residencies and medical school said was that we're taught to ask, do you have sex with men, women, or both? But we need to be a little bit more in depth than that. Instead of saying, do you have sex with men, women, or both? We then sometimes have to clarify, what does sex mean to you? What type of sex do you engage in? And then we should also know some terminology. So things like top surgery, bottom surgery, those types of things. If a patient's coming in saying they have top surgery, meaning that they've had their breasts removed or they've had breasts added, or bottom surgery, meaning, changing a penis to a vagina or vice versa. I also say you can introduce yourself with pronouns. A lot of the feedback that we get and things that other people say is that pronouns are hard. I personally think that we've learned all the pronouns we're going to learn since elementary school. Okay, so there's Z and Zer that have been added to it that makes it very difficult, but I often hear people say, all the pronouns, I just can't keep up with all the pronouns. So avoid keeping up with all the pronouns and just ask the patient. But you can actually do it in a way that's a lot more more aligning with you as an ally. And you can introduce yourself with your pronouns. Hi, my name is Dr. Rivera. I use he and him. What's your name? And immediately that sets you up with the patient. They know you know the lingo. They know you're cool. And it gives them an opportunity to introduce their pronouns without that awkward conversation about asking for their pronouns. Because that's what people say, right? It's hard to ask what pronouns are. I don't know when to bring it up. I don't know how. So just introduce yourself with your pronouns. We talk about explaining why you're performing certain exams. I don't know if you've seen me examine patients, but this is something that I believe in fully with any patient, that we should always be explaining why we're examining them and what we're doing and what we're looking for while we're doing it as we do it. In that same survey that Logan did with transgender patients, one of the patients was in a car accident, and they were in the emergency room after a car accident. And the doctor, the way that they described it was the doctor was feeling my pelvis for some reason, and put their hands on my pelvis and rocked back and forth and pushed on my pelvis. And I wasn't sure if the doctor was trying to decide if I was a male or a female based on the size of my pelvis. When in reality, this is just a standard secondary survey in a trauma accident, but nobody explained to this patient what was going on, and they felt very almost assaulted by the medical examination. The other one that came up today, cremasteric reflex. If you have a transgender female patient who has not had bottom surgery yet, and you are concerned for testicular torsion, you may need to do a cremasteric reflex. And the whole idea of stroking the inner portion of somebody's thigh while doing an exam is kind of an intimate act for most people. And so we should explain why and what we're doing before just reaching in between someone's legs and grabbing or stroking or whatever. One of the biggest things that comes in all of these surveys is do not ask questions out of personal curiosity. This is one of the ones where people say things like, oh, well, you know, do you have a penis or a vagina? And if it's related to ankle pain, it's not important whether the patient has a penis or a vagina. And while we may have personal curiosities, it's more important to answer our curiosities through literature review and research than it is to ask the patients, unless we're in an environment where we've gotten permission from them to ask these types of questions. And it's okay, you can ask permission, but give the patient the chance to say they're not interested in answering those. And it shouldn't be a standard part of your medical history. So we talk about creating policies for protecting the gender pronouns and patient privacy. Some patients don't want to know if they are transgender or not, but they would like us to, you know, so there are ways we can document our charts for it. A lot of hospitals institute the pronoun buttons, which are you wear your pronouns on your shirt or badge, and the patients can take a button out of the bin when they come in. It's mostly done in like primary LGBT serving institutions like Callan Lord in Manhattan and things like that. But a lot of larger institutions in California especially are instituting email pronouns where people at their signatures put their pronouns in the names at the end of their signature. And then not examining patients in the hallways. Some hospitals institute a policy of like individual rooms or putting transgender patients behind, like in our hospital, behind the curtains or in an individual room to protect their privacy. Sometimes that's a problem here. We can't even get sensitive exams put in rooms and hallways or put in hallways, but it's something that we should make a concerted effort to do. And then one that I feel very strongly is correct others who harm the patient or apologize when you harm the patient, but also let the patient know you did that. I can't tell you how many times I've been in the ER and had a transgender patient misgendered by the staff multiple times. And even after correcting them, had the faculty or the PCA continue to misgender the patient. And I basically told the PCA that if they weren't able to use the proper gender pronouns, then they should just not see the patient anymore. I'll find someone else to get the vitals. And I feel like it's our opportunity not to, like, if you correct the person in front of the patient, that's a whole nother set of issues. And that's not necessarily appropriate to do that coaching separately or to do that in front of the patient, but it can be done separately. But just let the patient know because they were offended. And you can say, I'm sorry that that person was unable to use the proper gender pronouns, but I corrected them. And, you know, thank you for understanding. I'm sorry that happened. So it's something that we can do to continue to improve and recognize when the system fails somebody, and then actually apologize for it. So somebody at home just said they're not our Google or Wikipedia, and it's not our responsibility. It's not the patient's responsibility to teach us about anatomy, physiology, and medical treatments. I love it. Perfect. And then the other thing that as we are coming through the last couple of months, and I've watched so many of us who are participating in rallies, who are creating movements, and who are doing so much for the community, we have to continue that momentum for our patients who are at risk also, and create and support legislation that decriminalizes being LGBT, but also supports our patients when they seek out care. Okay, so this is good. Questions from the audience? Any examples of things that you might have been uncomfortable with or you want to discuss? And see how you can make it through a potentially uncomfortable interaction.
I think one of the things you brought up and Mark brought up too is that we're going to make mistakes, and the key is to apologize. And I do the same thing where, let's say a patient was mistriaged, and then I ask the right questions and I get the right pronouns. I go back and I tell the team, and I go back and I tell the charge nurse and the nurse gets the patient. And I tell the patient, I'm going to let the team know. And still there might be errors, but I make that point of saying, okay, now I know, and I'm going to make sure everyone else knows in an attempt to not cause you this discomfort.
Absolutely. Good. And we can do better by making it part of our sign-outs too. Like Daharkas showed in documenting, similarly when you're signing out to floor patients or to surgery, or when someone's coming in who may not have the opportunity, if you're calling in a consultant, you can make sure they have that history up front so they're not making this face when they get the history, or if they don't get the history, or they're undressing the patient and they, aren't able to hide their emotional responses to things. So good.
Hi, Ronnie, this is Angela. Can I ask a question?
Sure, please.
Can you talk about if you do want to take a basic sexual history on a patient, like what are your standard questions? Do you have an alternative to the, like who do you have sex with, men, women, or both?
So I actually personally feel like who do you have sex with, men, women, or both is a really important question because it takes away judgment. Especially if you say it without judgment, it gives the patient an opportunity to tell everybody that they, to say whatever they want without judgment. The other thing that I think is important is separating between insertive and receptive sex, because some people only participate in insertive sex and some people only participate in receptive sex. And then I also think it's important to differentiate between other types of sex, like oral or anal. In the LGBT community, especially recently, there's been a rise in substance use with sexual activity as well. So sometimes it's important to ask if substances are used, not just like methamphetamines or cocaine, but also like GHB, and also poppers and things like that, which are amyl nitrate that people use during sex, which can cause, especially in things with there's like syncope or palpitations or arrhythmia that the patient is presenting for, especially for patients who use sexual aids like Viagra or Cialis and use poppers. They're both vasodilators, and you can get hypotension and syncope from those as well as cardiac arrest. So some of those things are standard. And then I also ask the patient often to define what that means to them, especially if they're using kind of vague terms that they don't feel comfortable. I say, well, what does that mean to you? What does I have sex with men mean to you? And they'll say, oh, I only like to have oral sex, or I only like to have vaginal penetrative sex, or I only use toys. Those are things that might come up. So it's always easiest to just ask the patient what that means to them, because everybody's and that's part of this, the framing it in that sex positive way, right? Everyone's sex is going to be different. What does that mean for you? So open-ended questions is probably the best thing to go with in these situations. Does that answer your question, Angela?
Yes, thank you. Perfect.
Okay. So in looking at patients with HIV, some of the problems we experience, legality again, many states in the United States criminalize HIV, saying that if you do not disclose to your partners that you're HIV positive, regardless of your viral load or control, then you can be arrested and jailed for exposing that person to HIV or putting them at risk. There's this element of solitude. There's this element of alone that comes from having a disease that interferes with your ability to interact with people in all aspects of your life and livelihood. There's also an element of shame. Sexually transmitted infections especially come with an element of shame, because there's this framework that we're responsible for our own actions that cause us to have sexually transmitted infections, especially HIV. There's access to medications. A lot of people don't want to take medications every day because they live with a family member or a partner who might see those medications and ask questions. It's difficult to maintain the every 3 months to every 6 month appointments that are required to get the medications re-prescribed to you, and do all the blood work that's associated with it. There's also the cost of the medications. I don't know if you know, but the average cost of medications for an HIV-positive individual is like $40,000 a year. And a lot of it isn't even covered by insurance. That most of the drug companies like Gilead give these like prescription cards to their patients that cover about, I want to say 20 to 30,000 of the cost, and then the rest is covered by insurance. So it can be incredibly expensive in the United States. It's true. In other countries, it's much cheaper. Fewer than 2/3 of people living with HIV are considered virally suppressed or adequately suppressed. And that's usually based on research data from lack of access, the cost, and fear of treatment. So the other thing that we have to remember is this isolation and stigma can really be compounded from undesirable traits, socially undesirable traits that are associated with HIV, poverty, drug use, homosexuality. We talked about the legality, and then navigating disclosure is another really hard part of this that we have to remember for our patients. At what point in your relationship do you tell your partner that you're HIV positive? Do you disclose it on the first date? Do you disclose it when you meet them and you're planning on having the first date? Do you disclose it right before the first sexual encounter? Does it matter if it's oral sex versus penetrative sex versus when? It's really difficult to navigate. So to kind of give you a sense of what people with HIV might go through, these are some of the thoughts that came out of a research study, or some of the things that people were jotted down their thoughts when they were seeking out care. So I'm going to read them to you and just give you a second to think about them. But I may have tuberculosis. I am criminalized. I don't have access to treatment. I face discrimination from health staff. My status was disclosed without my consent. I can be arrested for exposing my partner to HIV. My family may reject me. I'm scared that I will lose my job. I have no one who understands. I have a right to dignified care. And also on the more positive side, I had the courage to seek out treatment and care. I'm proud to help my peers who are living with HIV. So this is a very complicated slide that goes over some of the, it's called intersectional framing. It's basically looking at some of the factors that affect whether someone will ultimately engage in care and have a positive outcome, which is viral load reduction and reduced CD4 count, or sorry, normal CD4 count. So you start at the top with things like structural stigma, and this is a macro level item. Basically refers to attitudes in societies, practices among medical providers, structures of healthcare, services and laws that work to disadvantage what we call minority groups. This is not just people with HIV, but minority groups in general, the poor, homeless, people of color. So this emphasizes the framework of understanding how people with multiple social statuses intersect at a higher level, and then it affects the lower level of things like access to care or successive care. So we're looking at HIV stigma, racism, sexism, heterosexism, classism, socioeconomic status. In this chart, internalized stigma, in the section on HIV-related stigma, that's probably one of the most influential aspects and barriers to seeking care. And according to the fundamental cause theory for this stigma framework, people with multiple stigmatized identities have worse health outcomes because of a few mechanisms. The first one is reduced availability of resources such as power, which we forget power is a social resource, social status, social connections, and financial resources. There's social isolation and lack of social support, maladaptive psychological behavior and behavior responses. So bad coping strategies like avoidance, drinking, doing drugs to avoid emotional states. And then physiologic stress responses that negatively affect health outcomes in the long term. So we know that long-term states of stress have effects on the body and the immune system. And so those kinds of things can also lead to poor outcomes. Okay, so what can we do? Recognize your own personal biases when approaching the situation. So I start with an exercise of questions for you. How do you feel about people with HIV? You don't have to answer out loud, you can just think about it. Would you sleep with someone who has HIV? Would you sleep with someone who has HIV and was virally suppressed? Would you sleep with someone who has HIV who was virally suppressed without using a condom or some other barrier of protection? So in thinking about our own personal responses to these questions, we can kind of get a sense of what someone with HIV endures every time they interact with someone else in a social setting or in a medical setting. And so if we recognize our own personal biases and then we recognize that they're biases, then we can hope to overcome them and interact with the patient without projecting those biases onto the person. So that's where I talk about recognizing the framework. Be aware of privacy. We often do this, patient has been diagnosed with high five, and I'm gonna challenge us all to stop using the term high five, because I don't want a high five because of HIV. It just kind of is a weird term. I recommend seropositive instead. It's a little bit more discreet, but also making sure that we lower our voices when having these discussions, because we have an open ER and patients who have these issues, their privacy is important. And don't ask questions out of personal curiosity again. This is another one that becomes important. Patient once told me that they disclosed their HIV status to a medical provider and they were asked if they were raped. Because the person didn't think that they fit in the social category that they assigned to patients with HIV and couldn't believe that that person would have HIV from any other mechanism other than rape, I guess. So it's not our place to ask those types of questions. Yeah.
What do you think about the question in general? How do you contact? I find people ask it, but I don't know what bearing it has.
I think if it's a first-time encounter for someone who is HIV positive and they're like seeking out their infectious disease care to like modify risk behaviors, it might be appropriate. But in the emergency room, if it's something that if it's not related to the care, I don't think it's an important question to ask. I don't ever ask that question unless unless I'm diagnosing someone for the first time. I might ask questions to try to figure out how it happened to help them more than to help me. This is a really controversial one. It's come up many times that we all know, sometimes nights out with Ronnie, this one comes up a lot. But reframing the sexually transmitted infection as a fundamental part of adult sexual experiences. And this is that sex positive framework, understanding that we are in the middle of a pandemic and we can't even get people around us to wear masks to prevent the spread of a viral respiratory illness that's deadly. But we're getting to the point where we're starting to socially shame them now. But in general, we didn't shame people who go to work when they're sick and expose other people to illnesses. We don't get a cold during cold season and go, who gave me this damn cold? I'm gonna find them and I'm gonna rail them through Facebook and ruin them socially for giving me this disease. So I think when people come in, there's all this shame that we put on people that sexually transmitted infections are your fault. You didn't protect yourself. You didn't do these things. And it's not always the case. And we are taught in medicine that we can prevent these things, but we aren't taught in medicine to reframe it as this is a risk that happens when you engage in adult sexual activities. And understanding that risk is part of our positive framework in the sex positive movement, that you engage in sex knowing that a STI is a risk. You engage in certain types of sex knowing that your risk of contracting a sexually transmitted infection is higher. And as long as the patient made that decision at some point, as long as it was consensual. And we have to respect that and not shame them for making that decision, because we make stupid decisions all the time. And we don't get shamed for those. And our medical providers don't. I mean, we don't shame our patients for not taking their diabetic medications or their blood pressure medications. Well, sometimes we do. Should we? Do we get that? Okay. So another one is offer outpatient resources for patients who are at risk or fall out of care. I think this is something we forget in the emergency room, that we come in and someone's like, no, I'm out of meds. I haven't been taking my meds, these types of things. If someone's fallen out of the care, we really got to try to plug them back into care, because these are at-risk people for falling out of care. Correct others who harm the patient and apologize. We talked about that before, and support legislation decriminalizing HIV and improving the process. Sorry, I'm running long, so I'm going to go a little bit faster. Any questions at home? Anybody here? Yes.
So we have patients who come in and they say, oh, we haven't taken our heart medication for XYZ, and they try to describe it, but we don't know what they were on.
Mm-hmm.
So I guess like we just refer them to the START clinic.
Yeah.
And how quick those appointments happen with such COVID.
Yeah, so this is important. It's difficult because you don't want to start a different med, because there can be resistance issues. If you don't know their genotype or whether it's wild type or a different type of HIV, these are things that you have to take into consideration. Also, some patients, especially our patients in county, are on complicated medication regimens that are more than just triple therapy. Sometimes they're on quadruple therapy and more. So unless you're really, really familiar with it, I would refer them and try to get an appointment for them before they leave. Our Star Clinic is good.
Clinic never stops seeing patients who have the appointment.
Exactly. I was gonna say, I think the Star Clinic was open for everyone, if not by telephone, in person. And then we should, if you can't, then we should get our social workers to find somebody who can get them into care quickly, or a place where they can access care quickly. I like Cal and Lord in Manhattan. They're trying to open a Brooklyn site, but they haven't opened it yet. But Cal and Lord is like a free LGBT center for people who are insured or uninsured.
If you're in a setting that like there's no Star Clinic for a few hours, whatever, what recommendation like the discharge, but
Yeah, so
there's no amlodipine for HIV.
correct. So the HIV medications, they have a long-term effect, right? It's not like you're not going to take the med now and you're going to become, your viral load is going to be suppressed in a day or two. So it's important that we get them back on their meds, and also important that we normalize missing a dose, because HIV medications have, through like the PrEP trials and stuff, have been shown to be effective with 4 doses or more a week, for coverage. On average. And so if someone misses a dose, we encourage them to make sure they get every dose, because we don't want them to miss them, but also understanding that it's not going to have like the long-term, it's like blood pressure, the long-term effects are better. We want to make sure that it's suppressed for the long-term effects, not for the immediate effect. So it's okay to delay a couple of days, a week, unless there's some sort of underlying medical condition like a pneumonia or like an intracerebral infection or something like that we have to address. Exactly. Okay, so I'll go a little bit faster through the next one so that we can finish on time. Miscarriage. So problems associated with miscarriage. One is this is an incredibly emotional time for many reasons for a patient. There's fear, there's anxiety, there's disappointment, there is self-blame. This is often an emergency problem, right? The patients who are pregnant, bleeding, the first place they go is not to their OB/GYN doctor's office, because it always happens at 10 o'clock at night on a Friday. I don't know why, it just always does. And then this is one of the few medical conditions where other members of the family are heavily involved in the decision-making process, right? There's a partner who's involved in the pregnancy, and people who have announced their pregnancies to their family now have all these other people looking in, wanting to know what's going on and putting pressure and having an opinion in the situation, unfortunately. And also pain. This is a time when there's a lot of physical pain, as well as emotional pain. In a survey of patients who experienced miscarriage, this was like an online survey targeting the patient and the patient's partners. 45% of the patients who were surveyed said that they did not feel that they received adequate medical or emotional support for their miscarriage. So I apologize for the blurriness of this. It was actually published blurry. And it gets worse when you blow it up. But this Bardos et al., they surveyed 1,100 individuals who had experienced a miscarriage at or before the 20-week mark. And about 60%, so basically this is what the patient believed was their cause of miscarriage. So it's great, a lot of people recognize genetic abnormalities as one of them, but look how many people thought a stressful event could cause the miscarriage, or that they lifted a heavy object and they caused the miscarriage. A lot of people, 31% believed a past abortion would actually put them at risk for a miscarriage. Even almost 25% of people felt like not wanting the pregnancy caused the miscarriage. So these are some really important emotional things that we need to consider when the patient is coming in and we're trying to get the ultrasound and, make sure the baby, see if there's a heartbeat, do a vaginal exam, and do all these things without giving space to some of these thoughts and emotions. But just to give you some background, about 60% of miscarriages are due to aneuploidy. Other important causes of miscarriage are abnormalities in the uterus, such as fibroids or a uterine septum. There can be thrombophlebitis, like we talked about antiphospholipid syndrome in the past, or endocrine disorders like hypothyroidism, and then some autoimmune disorders as well. But continuing on with the feelings, this is a survey of the main feelings that were experienced during the survey. So a lot of guilt, a lot of people feeling alone, a lot of people felt like they did something wrong or could have prevented the miscarriage, and a lot of ashamed. So what can we do? I'm a big advocate for changing our words. I think we have to stop using the term threatened abortion, missed abortion, spontaneous abortion, because a person who is in the middle of a wanted pregnancy who comes in and we start saying the word abortion, that can be rough, and that puts the blame back on the person, that we're trying to remove that blame from them. Or even saying things like early pregnancy loss, because it's a loss, and it honors the fact that this is a loss to the individual who's experiencing it, but also gives them a nice framing of the event. Speak with the patient alone, and then speak with the spouse, because this happens a lot in our community here, where if you talk to the female patient, you may find out that they didn't want the pregnancy, and that the husband is going to be very upset. And I've actually had an experience where a patient asked me to make sure I told the husband that it wasn't her fault, and explain to him that she didn't do anything to cause this miscarriage, because he was suspicious that she didn't want the pregnancy, and it was like her third kid, and or it was going to be her fourth kid, and she didn't want any more kids, and which is another issue that comes into this, right? People being forced to have children that they may not necessarily want to in the framework of their relationship, which is not in line with our sex positive movement. I also talk about frame the frequency. I think we do a really poor job of this, of explaining to women how frequently this happens. Between 20 and 30-year-old, the 9 to 17% of pregnancies end up in a miscarriage. At 35, you get to 20 to 25%. And 40, you get 40 to 51%. And then above 45, you get greater than 80% of pregnancies can end in miscarriage. So that's huge. If we frame it for the patients like that and let them understand that it's part of the process of trying to have a child, it can really take away some of that blame. And then I talk about moving blame. 50 to 85% of, we talked about some say 60, some say 50, 80% are due to chromosomal abnormalities. And just saying that to the patient and putting it in terms of, when the sperm and the egg come together, sometimes they just don't fuse properly, and it doesn't make a proper baby. And this baby wouldn't have lived if it came to term. And this is your body's way of rejecting that improper mismatch. And framing it for the patient like that takes away a lot of the guilt for them. Okay, strength in numbers. What I mean is about 10 to 15% of pregnancies end in a miscarriage, and 1/3 of women will experience a miscarriage in their own lifetime. If you ask a patient, how many women in your family have had a miscarriage? They say, I don't know, because women don't talk about it to each other. And we don't frame it for them to say that there's all these miscarriages that happen, and it's an okay and natural part of having a baby. So encouraging them to speak with their female family members to talk about these things. Discussion about safety. It's generally accepted that you can wait a week and then you can start trying again. We used to say you have to wait 3 months, you have to wait several months in order to try again, but patients can try again as soon as their next period starts. As long as there's no medical issues that preclude it, let's say they had retained products or something like that, and they had to have a procedure, and then there's risk for infection. Refer for outpatient therapy and services. I think we don't often include a referral to psychology or psychiatry with our discharges for miscarriage, knowing that many women will experience some significant emotions, and as will their partners, and will likely need some sort of outpatient therapy to go along with that. So something we could do. Okay. Questions, thoughts, examples. 50%, someone wrote, Sarah Jones, or I think in general, 50% of all pregnancies end in miscarriage, mostly before the first missed period, correct? Okay, cool. So the next one is unwanted pregnancy. So the problems are, again, we come back to religious, this social framework from the perspective of religion. Legality about when, who, what can happen in an abortion affects women who are seeking an unwanted to end an unwanted pregnancy. Again, we come back to the emotional aspects of this. This is a very trying time. Many women are alone when they come in for this procedure and haven't told family members or friends. It often happens in the emergency room that the person is diagnosed with a pregnancy for the first time due to either vaginal bleeding or abdominal pain. So it's very relevant to our practice. And again, we talk about this social isolation, the feeling of being alone. It's estimated by the World Health Organization that 45% of abortions are considered unsafe. So that's about 22 million unsafe abortions worldwide. 4.7 to 13% of maternal deaths come from an unsafe abortion. The rates are probably the highest in women 20 to 24, which is 19 per thousand, and ages 25 to 29 is about 18 per thousand. Let's see here. By racial group, 38 per 1,000 are non-Hispanic Black, 35 per 1,000 are non-Hispanic White, and 18.8 are Hispanic, and 8.2 for other races. Your highest risk factor for having a complication of abortion or death from abortion is being younger, poor, or single. Those are the highest associated risk factors. The treatments, we have medical and surgical therapies that are available. We generally say that the medical therapy is 10 to 11 weeks, but above 12, most places will not allow above 12, and it's considered 95 to 98% effective. Surgical is anytime after that, depending on what state you live in, and considered 99% effective. We should know that medical pregnancy termination is 5.2% ER rate visit afterwards, approximately, and surgical is about a 1.3% ER visit afterwards. So the medical can be painful, it can be bloody, it can be uncomfortable, and so we see a lot of these patients in the ER after the fact, maybe not even for the primary. So what can we do? Again, change our language. Abortion versus unwanted pregnancy. We also have to frame when we talk to patients about pregnancy. I think this is something that we do very poorly. If we are in there and we're doing an ultrasound, there are some standard questions we can ask a patient to make this a more comfortable situation. Instead of saying, you know, you're pregnant, or, you know, you're gonna have a baby, congratulations. We shouldn't be doing those things because we don't know what this means to this person. We can say things like, your pregnancy test was positive. Was that something you were expecting? Okay. Given that this is a surprise pregnancy, is this a pregnancy you'd like to continue or a pregnancy you don't want to continue? Instead of saying, do you want to terminate the pregnancy? Do you want to end the pregnancy? Do you want to have an abortion? You can frame it in a little bit different way, giving the patient a chance to truly express what they feel without those social or verbal cues of what they should do, according to the society that they live in. Remove the blame. Again, pregnancy is just like an STI. It's an expected complication of adult sexual interrelationships. So if you frame it in that perspective and understand that it happens and it's not the patient's fault that they got pregnant, even especially if it's not their fault that they got pregnant, especially if this was something that is the product of a sexual assault. So set expectations for pain and bleeding. Our OBGYNs are terrible at this. They tell patients, it'll be fine, take the pill, you'll have some cramping and you'll be fine in 5 days. They don't tell the patient that they're gonna feel like they wanna die. They don't tell the patient that they're gonna bleed heavily or that they're gonna have, you know, clots and things like that. They just don't do it well. So we could do better. And then the other thing that we forget to do is to discuss contraceptive measures going forward. This patient came to you with an unwanted pregnancy. So we have an opportunity to talk to them about what potential contraceptive measures they have going forward to prevent future unwanted pregnancies. So something we can do to bring that care all around. Let's see here. So inform the patients we're here to help. Give them all of the options. So talk to them about medical therapy, talk to them about surgical therapy, when and how, so that they know that they have time to make the decision, or that they don't have a lot of time to make the decision. Reassure the patient that it won't affect their future pregnancies, because we have this social stigma to try to get women not to have abortions by telling them that if you have an abortion, you may not be able to have another pregnancy in the future. Complications from abortions that affect future pregnancies are exceedingly rare, and so it shouldn't be used as a way to guilt people into not pursuing and terminating an unwanted pregnancy. Assess their safety. Just make sure that they're going back to an environment where they're not being sexually assaulted or abused and being forced to get pregnant or sex trade, those kinds of things. So just assess the safety before discharging the patient, and then refer them for outpatient sexual health services, because this may be, they may be able to get an IUD placed, they may be able to have other STI checks and things like that that we didn't do in the ER that they may want afterwards as well. Okay, all right, I'm almost done, sorry, I'm going a little long. Any questions? Let's see. Ooh. Unwanted pregnancy, there may be an opportunity to talk about all the different kinds of contraceptive available, what types within their value system they are comfortable with, what's discreet enough so that they don't want to tell their spouses, etc. I'd like to add that early pregnancy loss is usually a sign that all the parts are working. So if you aren't sure you want to be pregnant, and know that you're very likely to get pregnant again in the next few months, if you want to, and you want to think about birth control, excellent. Some patients who present with vaginal bleeding and a positive pregnancy test are presenting post-medical or surgical abortion and don't dare say it unless you ask. So that can affect the workup and guidance. Good, that's a really important addition. Anything else in the live studio audience?
I'm just, I think it's a really important question to ask if expected, but also be aware that that's not a final.
Correct.
It could be a fluid thing, so just be careful about the decisions that you make as a provider, because in a week, someone may decide.
Or an hour.
Right, and we're fortunate, right? We're not going to be doing any of the procedures there and then, so we give the patient a chance to. We can refer them to the Women's Options Clinic here at Kings County, and they're excellent. I've actually read their notes and followed up on patients that I've referred there. But that's why I highlight it's really important to understand the timing of the different medical versus surgical, because some people are very against the surgical version of pregnancy termination and want to do medical. So as long as you can date properly and give them a sense of when they're able to do that, you give them more time to think about these things. And encourage them to speak to their partner or their spouse. Again, we're framing this in a sex positive way. So we're hoping they're in a relationship where they can discuss this with their partners. And if the partner's not around or available, then see if they need any other resources from us or other people that they'd like to talk to about it. Also important to make sure who's in the room and who's not in the room with these ones also, because you don't want to tell a woman she's pregnant in front of her partner and then have it be one of those things where she can't make decisions on her own, okay? All right, last one. Sorry, I used the word rape on here, but sexual assault is what I intended to say. So the problems here, this is a fine balance for us between medical care and emotional care. It's not one of those situations where it's very straightforward medicine. This one has a lot of emotional care, and because it's a very difficult situation. Intimate partner violence and violence in general. Up to 2/3 of patients presenting to the emergency department with a sexual assault will have some form of generalized body trauma that we need to be aware of. This can affect relationships going forward for these patients. They may not be able to sustain or maintain relationships in the way that they desire in the future because of this, and because of PTSD associated with this. There's risk of sexually transmitted infection, and there's also risk of pregnancy. So we have to remember that sexual assault affects men, women, and children, and the elderly. 1/3 of women will be sexually assaulted in their life, and approximately 1 in 30 men will be sexually assaulted in their life. The really scary part is that half of these people will seek care for the sexual assault, and it's usually in the emergency room. Teenagers are the most highly affected, but other at-risk populations we have to be aware of are patients with psychiatric disease, the elderly, and patients with developmental delays. So I'm going to go real quick and see what can we do. Change the language. We have to be really careful. Sometimes it's hard to know what to say. So I'm going to give you some of my suggested things you can say to your patients. One is, I believe you, and I'm sorry this happened. This is not your fault. You are not alone. This happens to many people, and I know it can be difficult to talk about. I'm here to help you. Let's talk about how I can best do that. Who do you want to be able to visit you while you're here? Do you have a safe place to go? I feel like it's really important that we do the who do you want, who do you not want in the room, because many of these patients come in with 5 or 6 big burly police officers who may look exactly like the person who just sexually assaulted them. And it can be very triggering to be in the room with those people. I ask the patient, do you want a male or a female doctor to talk about this? Because I may look like the person who sexually assaulted them, which may make it difficult to have this discussion with me. So we have to be really incredibly aware of those things. We do a great job here of the team-based approach, SART, whether we love them or not. They are experts, and many of our nurses are now trained. I don't know if you know, but many of our nurses have been trained in SART now and are excellent at it. And then prophylaxis, so just make sure that you're giving pregnancy and STI prophylaxis to patients to what applies. Documentation is so important. So we have to, because it can become legal evidence. So you have to avoid things like saying the patient was hysterical and unable to be examined or interviewed because of their emotional reactions, those kinds of things. You want to make no references to intoxication or the way that they were dressed or any history of STIs or anything like that people often put into their documentation because it has nothing to do with what's happening at the time. There is the ability through our hospital police to get emergency safety orders. So if this was something that they have intimate partner violence and they want a restraining order or they need to have protective orders placed, especially when children are involved, we can do that, and our hospital police can facilitate that. And then another one is we don't often give these patients a follow-up with psychiatry. So it's really important that we do that as well. Okay, so there is sometimes people don't feel comfortable asking their family members to leave the room, so it's easiest if you ask them to leave the room. Yeah, Roche was saying she usually asks everybody to step out, share the findings, and ask if they want me to invite them back in to talk. Never assume the patient in the room is their significant other or someone they trust. And then, Dr. Wolfram is saying, you are safe here is another phrase that we can say. Excellent. Anything here? Okay, I'm just going to say one thing to remember when we approach all these situations is something called the fundamental attribution error. This basically says that when we win an award, we say, I won the award because I am smart, I am talented, I am skilled. When someone else wins the award, we may say something like, that person is lucky, or that person, you know, got an easy break. Or in patient conditions, we may say things like, I got an STI because that person, you know, because you know, I use condoms all the time and I got an STI because I was unlucky. Or that person got an STI because they're dirty, or they're not safe, or they're stupid. And so we tend to think of the things that apply to us as inherent characteristics of our behavior. And then when it happens to somebody else, or sorry, for us, it's situational when it applies to us, but with other people, it's inherent characteristics of them that make them either successes or failures. So we have to try to remember that we allow ourselves to be victims of circumstance and situation. Our patients should also, and the people we interact with on a daily basis should also be, we should allow them to be victims of circumstance also. I am a big fan of the 4 C's of patient care. I don't know if you've ever precepted with me, I talk about them a lot. So culture, understanding the culture in which the situation is happening, understanding the care that the person is entitled to and deserves, and explaining the care and why you want to do things, communication, and then collaborating with the patient, asking them what they want to do, asking them what they are comfortable or not comfortable with doing before doing anything. I'm going to skip this slide because basically it just sums up what we said today, which is everything contributes to our patients' presentations, and our patients that we see are some of the highest risk patients in the world, maybe more in our country than in the world, but we have to be aware of that, and we have to understand what contributes to why they present to us and why they're such high-risk patients. So yeah, address our own personal attitudes and biases, change our language, and just like you have been doing, continue to make changes at the hospital level and state and federal levels. These are my references, and I just want to say thank you to my mentors, Dr. Kim, Dr. Smith, Dr. Renner, Dr. Lucchese, Dr. Willis, and just for fun, this is a picture of Dr. Willis hula hooping. I want to say thank you to my class. This has been an incredible 4-year journey, and I can't believe it's coming to an end right now, and it's just my allergies are acting up. I couldn't have asked for a better group of people to go through this with. There were a lot of ups and downs, and you guys made it incredible. Thank you. We finally did it. And just for fun, you guys, I know it's common to share a bunch of crazy pictures of ourselves. So thank you to all of our nurses and support staff who have also been there for us and you know, with us every day, shaping us and helping us to grow. And then just mostly the rest of you, thank you for letting me be the glittery rainbow unicorn princess drag queen butterfly that I am. I appreciate you giving me such a wonderfully safe space to be myself in and to just enjoy the last 4 years with all of you. Thank you so much. I'm just looking to see if anybody said it. Anybody else at home? Okay. All right. I think it.
I have one thing.
Yeah.
I love how you stress about communication, and also the recurring theme seems to be like, let the patient talk, let the patient tell you what's up. And you know, we have this inclination. I'm especially guilty of it. I just want yes/no questions, right? 2.5 minute interview, you know, but that's not really the way to do a lot of things. And so like the pregnancy, is this what you expected question? Like that's what, you know, open-ended questions.
And it starts out slow, it really does. And you will notice that you slow down a little bit to do these things, but after a while it just becomes quick and repetitive, and you can get through it pretty quickly. And you start to be able to gauge the patient and their responses, and also know how far you have to go or not how far you have to go into certain lines of questioning. So it becomes habit. Oh, Fabi, is that you? Hi, Fabi.
Fabi? Hi, Fabi. Daar estás. Ronnie. Ronnie.
So Ben, for those of you at home, you asked to repeat the question. Ben was saying just, it seems like letting the patient talk and giving the patient space to answer questions, and really open-ended questions are going to be big for these types of things as well. And then you were saying, sorry.
Just reiterate, I really feel like the patient's going to give you most of the information.
Ronnie, we're going to miss you. You've been great. And one thing I don't know if everybody knows, but the medical students have always talked great about you and how your teaching is. And I teach a lot of the medical students, and the person they mention the most is you.
Thank you very much, Dr. G. Awesome. Well, thank you all very much. I appreciate it. Hi, Fabi. Oh, sorry.